doing a case presentation on multiple pituitary microadenomas. So this is something that I saw in the outpatient clinic. I'm a PGY2 and in internal medicine, and I thought it was a very interesting case because we typically follow algorithms for diagnosing patients, and this was a very good example of why we should continue to do that. So goals of my lecture is essentially to highlight this importance of following that guideline-directed algorithm and exploring the differential diagnoses that we always suspect with patients that come in with a certain set of symptoms. So this patient had very common symptoms that you would expect in a young female, and finding the ultimate diagnosis was not an expectation. So this is kind of just going over and understanding the importance of considering all of these differentials. So my screen is a bit odd. Okay, so this was a 33-year-old female, and she had a past medical history significant for anxiety and migraines. And I mean, how many of us don't have that? But it was presented in the clinic, and she came in with unable to achieve weight loss. So she actually works as a nurse, and she was covering a lot of night shifts and having a lot of stress and anxiety with personal life and work life. She was on alprazolam, and she was doing a lot of efforts to lose weight, including diet and exercising, yet this was not working for her. Her home medications included sumatriptan, escitalopram, and alprazolam. So she was very fatigued, complained of that anxiety and the weight gain. So a workup was done with a CBC, CMP, and those were unremarkable. And we conducted a cortisol level, with the low dose dexamethasone suppression test. And initially I thought it was a bit of a reach to be doing this, but it ultimately deemed to be revealing that the AM cortisol was a normal result when it should be a suppressed level. So then ultimately, if you follow the algorithm, this requires the further investigation. So as you do the low dose dexamethasone suppression test, it shows the unsuppressed level. We then obtained 2 separate salivary cortisol levels, which were elevated. So she had hypercortisolism, and the differentials including Cushing's, PCOS, liver disease, could be from medications, adrenal adenoma. So we had to explore all of these differentials. It could be divided into ACTH independent or dependent, and to further differentiate that, ACTH levels were obtained 31 and 38 that were abnormally normal. So that ultimately indicates a secondary hypercortisolism. When the secondary ACTH dependent hypercortisolism is in play, then the further workup can include an MRI of pituitary, and it's like a special type of MRI other than like the normal brain MRI. So these findings were done, and it ultimately showed 2 separate pituitary microadenomas, which is not the usual of having like one solitary lesion. There was 2 separate findings, and this was very unusual presentation in a young female, and she was ultimately referred to neurosurgery, and inferior petrosal sinus sampling was completed, which showed the final result of Cushing's disease with hypersecretion from the left side of her pituitary. So she had consultations with the neurosurgeons. She had visited many of them and decided to have a surgical intervention to overall improve her quality of life. She ultimately had an endoscopic transfer resection. So after she had this resection, she had to have a revision surgery due to the uptrending cortisol levels. But after the revision surgery, she was started on hydrocortisone. Some complications of the procedure actually was diabetes insipidus. She was having those symptoms of polyuria and polydipsia. And then she was started on desmopressin every night due to these symptoms consistently. Her ultimate surgical pathology showed pituitary adenoma. And essentially, I found this case interesting because when you have a presentation like that, especially in an outpatient clinic, of a young female who's anxious, unable to lose weight, and working a lot of night shifts, you would kind of end it there. But by doing that extra step of exploring our differentials, essentially multiple pituitary adenomas were found. So that's kind of the main goal that I wanted to relay over, and I thought it was a very interesting case that I wanted to share with everybody. So I am open for questions now as well.
All right, we do have one question, and that's going to be, did the patient undergo other hormonal secretion testing for these microadenomas?
No, there was only the specific testing results that I had shared. There was no other hormone testing, but in the initial presentation, she was tested for like estrogen, testosterone levels, which all came normal. And so then the cortisol was an addition in that initial testing as well.